Shrikant for the talk on controlling myopia progression, the next step forward.
There will be slight overlap between my talk and the previous talk. So could we have the slide, please? Yeah. So just as we have finally got over the COVID pandemic, there's another epidemic silently brewing in the East, and that is the epidemic of myopia. The world has seen an exponential growth of myopia. It is estimated that almost 50% of the world population would be affected by 2050, and more than 10% are likely to be high myopia. Against this backdrop, I'll be presenting my talk, Controlling Myopia Progression, the next step forward. We all know that myopia increases slowly till about 8 to 10 years of age. After that, matching with the pubertal spurt, it increases almost linearly and rapidly till about 18 to 20 years of age and finally stabilizing there. And what do we offer as ophthalmologists? As the myopia keeps increasing, we just keep changing the spectacles and contact lenses, pacifying the patient that it's going to stabilize at around 20 years of age, and then we'll perform refractive surgery. It is as if we are allowing the fire to spread before trying to douse the fire. It's high time that we think differently. So if we have to control myopia, we have to act on the rising phase of myopia. Myopia provides us with a big window of opportunity to act. We just have to find some ways and means to control myopia in these years. So to control myopia, we need to understand as to why myopia increases. The most potent stimulus for progression of myopia is a peripheral hyperopic defocus. As a result, the eyeball tends to increase in size to bring this image onto the focus, onto the retina. It can be compared to phototropism as seen in plants, where plants tend to grow towards the source of light. So we can control myopia by making the sclera strong and preventing globe expansion, or by simply converting this peripheral hyperopic defocus into a myopic defocus, removing the stimulus for progression of myopia. Based on these concepts, there are various myopia treatment modalities are present. But before going into them, I'll touch upon the techniques under investigation. 2% pyrazipine gel is a selective M1 receptor antagonist. It has all the beneficial effects of atropine in myopia without any of its side effects. Scleral collagen cross-linking aims at making the sclera strong and prevent globe expansion. There's an increasing role of certain biomolecules like dopamine, 7-methylxanthine, and melatonin in myopia. Dopamine has been shown to have a protective effect in myopia. 7-methylxanthine strengthens the sclera, and melatonin has been found to be raised in myopia and has to do something with circadian rhythm. An increasing role of RPE has been seen in releasing growth factors which control the scleral modeling. So in near future, we may be seeing some newer modalities of treatment emerging out of this current research. Coming to the modalities in vogue, increased outdoor activities has been shown to reduce the onset of myopia and has minimal effect in reducing the progression of myopia. Pinhole glasses are being used by some, but it has got no effect in control of myopia. Progressive addition lenses and bifocal lenses have only a minimal role and is not a viable option for clinical application. Stellest glasses utilize concentric rings of highly aspherical lens slits. These create a myopic defocus similar to orthokeratology. In initial studies, they have shown promising results. Soft bifocal contact lenses and peripheral defocus modifying lenses also have a role in control of myopia, but the lenses with a segmental design have no role, as the hyperopic defocus is still present in them. Those lenses with a concentric lens design create a myopic defocus and help in controlling the progression of myopia. Orthokeratology has a very effective role in controlling myopia progression. This is the orthokeratology lens placed onto the eye. This central base curve is flat and it flattens the corneal epithelium, controlling the myopia. The peripheral reverse curve zone has space underneath where the corneal epithelium heaps up. So this concentric ring of heaped up corneal epithelium creates a myopic defocus which remains throughout the 24 hours, and therefore orthokeratology has a very effective role in controlling myopia progression. Atropine has been shown to have a beneficial effect. 0.01% atropine has been found to have least rebound effect, best clinical efficacy, and least side effects. Atropine acts in various ways, not just by inhibiting the accommodation. A direct influence of atropine on scleral fibroblasts is seen. Atropine has been found to inhibit myopia induction in avian eyes also. Avian eyes have nicotinic receptors. So it is thought that atropine can act at very low doses, and hence 0.01% atropine is very effective. Both atropine and orthokeratology are highly effective in controlling myopia progression. Orthokeratology, in addition, reverses the myopia, improves the unaided vision, and helps in removal of glasses. Children being spectacle free can participate in outdoor games, which may again have a beneficial effect in control of myopia progression. So control of myopia progression has become a reality today. There is sufficient evidence in literature to show the efficacy of orthokeratology and atropine in slowing down myopia progression. As we take the next step in future, orthokeratology and atropine have the potential to flatten this curve of myopia. If it is made possible one day, it will be a small step for man, but a giant leap for the mankind. Thank you.
Thank you, Dr. Shrikant. While Dr. Shreya is, you have one question? Yeah. Yeah.
Is this the right time for policy thinkers to come out with national myopia control program where strict decisions on environmental exposure like sunlight in school, because nowadays most of the schools run from 7 a.m. to 7 p.m. and they are hardly exposed to sunlight. Whether government rules have to come forward giving school instructions for 2 hours exposure to sunlight, and this should be made a policy matter. Because madam is there and
I think they would be the best person. Experts are already there, so maybe a quick comment from sir, maybe.
this is a very important aspect. Because other countries have already taken. China has taken a big leap in national myopia control, but we were the first to take in cataract blindness even
Okay.
before China and other countries, but we have not taken a step forward in this particular.
Myopia is more now, right now in China, Singapore, with Asian
Yes, they have already
countries, they are
taken
more.
steps.
But before we go to that stage, maybe it's a right thing to do. I think the recommendation, I mean, it's so many points that we have to think before advising. It's like
You can use.
what we are doing now for screening for school-going children for refractive error per se. There's a big program is going on under government, very big program. But are we justified in saying that we are covering the entire population of the children in screening? We are not doing it. And there is no compulsory program for that. Government is screening, but they are screening now and then they are giving spectacles next year. The children receive spectacles next year. So where is the gap? Even in that we are not successful. And if you are going to say this, all private schools are not going to comply. Now with all your plus 2 and then NEET, they are not going to comply with your outdoor activities. It's only my thing is the public, the parents should take it. And there was a new recent paper saying that outdoor activities Even Saturday, Sunday, if they go out for at a stretch few hours, that helps. So there are so many logistics that research has to be done before we come to this conclusion. I think this just proposing right
Yeah,
now.
yeah, we
Parental, wherever is possible by all of us here, wherever is possible in our own region, our own place, try to create awareness.
I think we have a myopia symposium for this, and maybe these questions can be well answered that time.